Hello and welcome again. I'm Dr. Anthony Gonzalez and welcome to Miami Community Health. We're here to talk to you today about another important health topic. And for me, as a surgeon, this is a super important topic for me. Why? Because we're talking about the hands today, and the hands are very important for me as a surgeon. I spend my life using my hands. I use my hands in the operating room, operating on patients, using them in manipulating robotic instrumentation, robotic surgery as well. So the hands are very important. And so I brought a friend, a colleague, and a orthopedic hand surgeon to be with us today, Dr. Roberto Miki. Welcome.
Thanks for inviting me, Tony. This is a great setup. This is incredible.
All right, well, welcome. So tell us a little bit about yourself.
Well, I'm originally from Miami, Florida, born and raised here. I was born at Jackson Memorial Hospital. I grew up here. My family's actually from Peru. I'm half Chinese, half Japanese from Peru. So kind of a crazy mix. We eat well in my house. Both my parents are physicians and sort of had an inkling that I wanted to do medicine, but I went to college and then decided to go into medicine and sort of fell into surgery almost by accident. I wanted to be a pediatrician actually when I went to med school, and then did surgery first just because I'm going to get it out of the way.
Yeah, I remember that.
Like a lot of surgeons, a lot of people in med school. So, and then I just fell in love with it. I mean, learning anatomy is incredible. It doesn't change. That's the one.
Yeah, that's true. All right, so let's talk about it. You're an orthopedic hand surgeon. And so what is an orthopedic hand surgeon? How much of the hand or the arm do you take care of?
So orthopedic hand surgeons differ. Some people do, for example, like myself, will do clavicle to fingertips. Other people will do even up to the brachial plexus coming out of the cervical spine. I do clavicle to fingertips. My partner, for example, does elbow down. And so we kind of limit to where we feel most comfortable. But in general, most orthopedic surgeons now who do hand surgery, do shoulder to fingertips, just because that's our area of expertise as far as the familiarity with the anatomy and whatnot. So
there is so much in the arm that we need a specialist just for the arm.
Well, I think that the problem with the hand in general is that when you have injuries in the hand specifically, you can have injuries to multiple structures, including arteries, nerves, bones, muscles, tendons. And so in general, orthopedic surgeons don't feel that comfortable with arteries and veins and nerves like, let's say, a vascular surgeon or a general surgeon. And so we get an additional year of training just to get more familiar with those things. And for example, in my fellowship, I had a general surgeon who was my co-fellow, and I probably learned more from him on how to handle the soft tissues and handle arteries and do those vascular things. And so the injuries that we have in the arm, specifically for hand, are for amputations. Sometimes I will even go into lower extremity if I have to repair an artery or nerve down there that's an amputation, whatnot, or someone has like a combination injury. So I don't, not exclusively upper extremity, but for the most part, most of the amputations that we deal with on a regular basis are in the upper extremity. So that's sort of the history of hand surgery. It came out of World War II because they found this gap. And so a lot of surgeons came together to sort of create this system. That's why you can be a general surgeon, plastic surgeon, or an orthopedic surgeon and become a hand surgeon. Yeah, because of that tradition.
All right, so we're going to talk about some of the common conditions that people have and common hand conditions, because as always, this is an informative show. This is a show to inform our viewers about common hand conditions. And the first one we're going to talk about is carpal tunnel syndrome. And carpal tunnel syndrome, of course, very common, and so common that Dr. Miki is taking care of my wife and my brother-in-law. So like I tell my patients, I send you to people that take care of my family, and I bring you as our viewers, people that take care of my family as well, and so forth. So what is carpal tunnel syndrome?
Well, carpal tunnel syndrome is a sort of syndrome that involves the median nerve. And basically most people who have it complain about numbness in their hand and sometimes weakness in the hand. In general, it's a syndrome that we see mostly in people like older women who have postmenopausal. Occasionally we'll see it after trauma, but basically it's the carpal tunnel sits here in the wrist, and the area becomes swollen for whatever reason, and it compresses the nerve, and then the nerve stops working well. And the first sort of symptoms are numbness in the fingers, and used specifically in these four fingers, and the pinky is usually spared.
Okay. And so, but there's certain people that are more at risk of having carpal tunnel than others, right?
Correct. I mentioned postmenopausal women, diabetics, people who have trauma, such as a major car accident. Those people.
How about the work that you do? If you use your hands a lot, are you going to have carpal tunnel?
So that's a mixed question or a mixed answer, because there's some evidence that typing causes carpal tunnel, and there's some evidence that typing doesn't cause carpal tunnel.
Oh.
There are some studies that show that, like, if you type for more than 4 hours a day, that you get carpal tunnel, and some that say you don't. So it's probably the fact that if you have the genetic background to get it and you do those jobs, yes, you're going to get it.
Okay.
But if you don't have the combination, you're not going to.
Okay, good, because I use my hands and I don't want to have carpal tunnel. All right. So how do you make the diagnosis of carpal tunnel syndrome?
So carpal tunnel syndrome technically is diagnosed by, history and physical examination. And so typically the person will complain of numbness in those 4 fingers. They will complain of night symptoms where it wakes them up in the middle of the night. They can't sleep. They have to shake their hands in the middle of the night. And a lot of the symptoms are sleep deprivation. And the next thing on the physical examinations, you'll notice that there's decreased sensation. We use something called a Symes-Weinstein filament, and we sort of measure how well the sensation is in the fingertips. And sometimes that will be decreased. We also do some tests called the Durkin's test, where we push directly on the median nerve, and that will sometimes elicit symptoms. And then the sort of confirmatory test is an EMG nerve conduction test, which is an electrical shock test, which usually will show that the patient has decreased nerve conduction, meaning that the speed of the nerve is decreased during carpal tunnel syndrome. And you can measure that, and you can sort of gauge how bad is it. Is it a mild? Is it a moderate? Is it severe? And that sort of gives the surgeon a better idea of, like, is this person ready for surgery?
And does everybody need to have a EMG test?
So that's a somewhat of a controversial topic as well, because not everyone who has carpal tunnel has a positive EMG. And some people will have a negative, especially if you're a younger person who has the problem, because as we get older, nerves kind of slow down a little bit. So typically the normal setting is around 45 meters per second. And some people, let's say their normal is 70, they drop 10%. They'll notice that, but they still don't fall below that 45 meters per second. So there is some controversy in that, and that's why that's why the diagnosis is a clinical diagnosis and not just a EMG. A test.
All right. So does everybody? So you have carpal tunnel, you have the numbness. I remember, my father-in-law, when he was alive, had it. My wife at night telling me her hands get numb. So you're concerned you have carpal tunnel. They go see you. Does everybody need surgery?
No. Many people will respond to just bracing at nighttime. And that's our first treatment is conservative bracing. You wear a brace every night to sleep. Basically, when you sleep, a lot of people sleep with their wrist bent in either direction. They sleep on it. They sleep in awkward positions, and that compresses the nerve more. In this neutral position, the nerve has the most space, and so it allows the nerve to recover. And so then you can abuse it during the day, and during the night it recovers. And so that's why a lot of people respond to bracing. The next step, if bracing doesn't work, is to inject a little steroid, and many people will respond to that. And in fact, it's a good thing to do before you do surgery, because it helps the surgeon confirm that the syndrome that we think you have is what you have. Because if I inject you in the wrist and it doesn't rid you of your symptoms, then I have to really concern that it's coming from your neck or from someplace else. The nerve is compressed, because that nerve goes from your fingertips all the way to your shoulder up to your neck. So it can be compressed along the whole course, but the most common place is in the wrist. But if I inject you and you don't get any response, then, we got to start looking for other things.
All right. So you've had injections, that's failed, and now you need surgery. So how is surgery done nowadays for carpal tunnel?
So surgery comes in basically 2 major forms. One is open, where we make an incision here on the palm of the hand. And the second option is endoscopic or minimally invasive. Some people do a mini open. Some people do an endoscopic. In the endoscopic or mini open, you make a smaller incision and then use an instrument to gain visualization. And I brought you a little example.
Yeah, show us what you brought us.
So this is normally we put a camera in the end of this, and then the camera has a 30-degree angle, so it comes out this little hole here, and you can see out the end of the knife here, and or the probe, and you stick this inside the wrist through the small incision here, and then you can cut the entire carpal tunnel from the length from right here to about here, and this little trigger here deploys a little knife, and that knife is what allows you to cut the carpal tunnel.
Yeah, there's a knife there, guys. I play with that. There's a knife. That's pretty. No, There's a knife. He told me, be careful. Don't put your finger there. There is a knife there for sure. All right. And is there a difference in the outcomes when you do them open versus endoscopically?
So based on the literature, there is absolutely no difference in outcome at 6 months to a year. Basically, everyone comes out the same, whether you have an endoscopic or an open carpal tunnel release. The main difference between endoscopic and open is in the initial phase. In that first 6 weeks, most people have an endoscopic do recuperate a little bit faster, can do higher level activities a little bit faster. Whether that's a week or 2 weeks is a difficult thing to completely assess for each person. I would say if you're a manual laborer, yeah, endoscopic, you're going to get back to doing manual labor type stuff faster. So for certain patients, we want to do endoscopic, and for some patients, we don't care which one we do. And in my practice, I let everyone choose. Some people will say, "Oh no, you only get endoscopic in my practice," but in my practice, we let everyone choose. There are some people who I will say, "No, you need an open carpal tunnel." Someone who's a revision case, someone who has severe muscle wasting, where I need to get a complete decompression, and I want to make sure that there's nothing left behind.
Okay, so you have the carpal tunnel syndrome. You've had it opened. You had the surgery for it. Can it come back?
Yeah, I mean, so about 10% of, the literature says about 10% chance at 10 years that it's going to come back, mainly because some of the process that's initially caused the carpal tunnel, swelling in the tendons, the postmenopausal type symptoms, all cause this to continue to proliferate, and so the compression just comes back. And so, we make the space bigger, but it doesn't mean you can't refill that space and recompress the nerve. But in general, most people by 10 years, don't. 90% of people don't have symptoms again.
So can you prevent carpal tunnel? Let's say we have a viewer who doesn't have carpal tunnel, and I don't want to have this because I don't want to have this blade stuck up my wrist. Can you prevent it?
There's no defined way of preventing it, but I think there are certain things that if you can avoid it. Like don't go out and use a jackhammer every day, because that has been shown to, using vibrational tools. So like if you are going to use a lot of vibrational tools like drills and things like, and you're, getting, you're not 20, maybe you wear a glove that has a little padding in it so that you absorb some of that shock.
Okay.
I remember as a young orthopedic surgeon in training, after doing my total joint rotation or using saws all day, I had carpal tunnel syndrome symptoms. I had started getting numbness, when I would, wake up in the morning, and it was because we were using saw. We're doing, 10 of these a day, and, you would get, so, sometimes I would ask for a third set of gloves just to, act for a little extra padding.
Wow. So we've gone over our first topic. We talked about carpal tunnel syndrome, and we know what it is now. We know how it can be treated. We know how we can use our little weapon here to take care of it. Obviously, try not to be using jackhammers all the time. But if you feel that numbness in your hands, especially in the middle of the night, then you may have carpal tunnel syndrome. Now, I want to move on to our next topic. And the next topic that Dr. Miki thought that would be important for us to talk about would be a distal radius fracture. So I know the radius is one of the bones in the arm, and distal means that there's a broken bone down lower here, right?
Correct.
So what is that? How does that occur? How do people get a distal radius fracture?
So distal radius fractures come in sort of two age groups. There's the really young, like, children, and young adults, like 20 somethings, who usually happen from like traumatic falls. For example, they're on the jungle gym. They fall off the jungle gym and they break their wrist. And then we have the more osteoporotic postmenopausal women who also seem to fall due to imbalance issues and whatnot. And because they're postmenopausal, their bone's a little bit weaker and it breaks for just a normal fall. And so it is a bone, it's the radius, it's the bone on this side, the thumb side of the wrist. And essentially that bone, if it's broken and it's displaced, probably needs surgery in an active person. In young children and young adults, we can often set it and it will stay. But in women who are postmenopausal and gentlemen and men who are a little bit older, if you set the bone, it often falls off. And that's actually been studied recently, where they actually were able to get perfect reductions. And they actually showed that even if you get a perfect reduction in the emergency room, there's a benefit to surgery because so many of those fall off.
So what he's talking about in reduction, to clarify, is that, they put the bone back in place, right?
Correct.
And then falling off, you mean that it doesn't heal well?
It doesn't stay there. It's like an ice cream on an ice cream cone. The ice cream falls off the ice cream cone.
Wow.
So,
that's not good.
No, it's not fun to tell a patient, though, we got to do this again.
All right. So what is surgery nowadays for this?
So surgery has been revolutionized. I mean, in about 2001. Prior to 2001, we were putting these medieval devices, external fixators. And I remember in residency, we would put these devices where we put 2 pins here, and we put this giant bar. And it was this medieval torture device. Patients would come back with RSD, which is this pain syndrome. I mean, you're well aware of that. It was just horrible. People hated it. And so many people would say, I don't want an X-Fix, I want a cast. And they would have these very poor outcomes. Patients were dissatisfied, they would have poor outcomes. But in about 2001, these new plates, because there was some new technology that came out called locking screws, allowed us to fix these bones and fix them very, very easily and very quickly with great outcomes, because you didn't have to wait to take it out to start therapy. So we make an incision here, we go down to the bone, and the nice thing is that we don't have to cut any muscles or tendons to get down there. We just dissect down, we find the bone, we put the bone back in place, and then we put this plate right here. There's another toy I brought. And basically, it's a plate that goes on the palm side of the wrist. And so this is a plastic bone, but this is a real plate, and this is the plate that's right here. And we basically put this plate here, and you can see it's hollow on the inside. You can see the small screws here and the bigger screws here. And basically, this piece is separated from this piece. So this plate acts like a little bridge between the two fragments of bone. And in about 6 to 8 weeks, the bone heals. So this plate doesn't have to be super strong, although it is super strong. According to the manufacturer, you could do a push-up with this on, and we don't suggest that, but it is. But here, Tony, you can play with it. It's a titanium plate. These were actually first started here in Miami.
Wow.
And it's a great story of innovation here in Miami. We talk about immigrants coming to the United States and how, people who think differently make a difference. And I mean, this is probably the prime example of, someone thinking outside the box, because they came from a different perspective. Everyone else was set on this external fixator thing, and someone said, no, we can do this better. And
wow, that's
and
awesome.
this is I mean,
so this is and somebody has this is outpatient surgery, they have this, they go home, no push-ups, of course, right? But and then how long to recover from this operation?
I mean, stitches are out in a week. You start therapy right away. Usually by 2 or 3 months, you're doing very well. Most people by 6 months, a lot of times are like, oh, which wrist is the one that was broken?
Wow.
Other than the scar, I mean, that's the only sign.
And you have to take this out later on?
So I may take out one of these per year. So 1 out of 100 or 1 out of 2, I do about 100 of these a year. So maybe 1 out of 100 we'll have to take out because someone doesn't like the way it feels or they have some anxiety about it. But from a complaint standpoint, no, these are extremely smooth. It's titanium. Your body thinks it's basically bone. It has the same elasticity as our bone. So the body doesn't reject it.
Now, let me ask you, so you have this done, and if that individual is to fall again, are they stronger on this side than on the other side?
Yeah. So I've actually had patients who have fallen again and, broken the other side, but not the side that's broken. The only person I've ever had who's broken the bone
and the plate
and had to have surgery again was someone who fell literally off of, he was a construction worker. He fell off the third story of a third story.
God.
And he broke the bone only because he bent the plate, but the plate did not break. Wow. And the bone didn't move it still was stuck to the plate. So he just bent the plate.
Wow, I'm so happy that guy's alive.
Yeah.
That is incredible.
But he put his hands out to stop himself.
Oh my God. All right. So that's incredible. And how common is this? This is very common, this type of fractures and
It is
breaks?
the most common fracture repaired in the body.
Wow. Yeah. Incredible. Well, so we've learned about carpal tunnel syndrome. We've learned about distal radius fracture. And now we're going to talk about a little weird condition, which I don't really know anything about. I had to actually look it up at least to even know how to pronounce it. It's called de Quervain's. I think it's like a tendonitis or something like that. Tendonitis is like an inflammation of the tendon for our viewers. And for those that don't know a lot about medicine, like or orthopedic medicine like me. So what is de Quervain's or de Quervain's? What is this?
So de Quervain's tenosynovitis is also called new mommy's wrist.
New mommy's wrist.
So
okay.
It's very common in women who have just delivered.
Okay.
Okay. Mainly because not that I know or but but a woman who's delivered usually has a lot of post swelling. And one of the pinch points in the wrist is actually on that bone right there is right at the radial styloid right here. And there's a tendon that goes in this little groove here, and actually 2 tendons. And if you're swollen at all, that space is too small. And so it hurts like crazy. And so you can imagine trying to lift a child like this, and this tendon right here is swollen. And how do you pick up a child? You pick up a child like this, and this tendon gets activated, and it's trying to go through a space that takes 1 millimeter and it's 2 millimeters big. And women will not be able to carry their babies. And so they present with severe pain. They present with, basically crying because they can't hold their child, and it's a terrible problem.
And it happens around the time of pregnancy because of the full body swelling that occurs, or because they're putting stress on that?
I think it's a combination of both. There's a hormonal change, a dramatic hormonal change, and then there's also, this new activity which, is not normal. Okay. And we also see it in new fathers too, and new grandparents.
Oh, because they're holding
the baby all the time.
And they don't have the swelling from postpartum, right? From after pregnancy. All right. So the mom's coming in, she's crying. She's got this new mommy syndrome, the wrist, the core veins, the curve veins. What is the treatment?
So initially it's bracing. And many women will respond to that. But most end up needing an injection of a steroid. The issue is just with breastfeeding and stuff like that. Sometimes we can't give the steroid if you're breastfeeding because the steroid does end up in the milk a little bit, and we do have to ask a clearance from the pediatrician or the obstetrician to say, hey, can I give a small dose of steroid? And there's sort of like some of them obstetricians, some of the pediatricians let us, some of them don't. So it's just sort of this thing that we just have to ask permission.
And then what about the negative consequences for the patient for the steroid injection? Could there be? Because we talked about steroid injections for carpal tunnel now. We've talked about steroid injections for the core veins. What are the negative consequences for patients?
One of the things that you can get is bleaching of the skin. And you'll get a big white spot right here on the end of the wrist. And basically, it's women don't like that, and guys don't like that either. And they don't like this big white spot here, especially in Miami where everyone's tan,
But that doesn't happen in the carpal tunnel.
No, because you're going much deeper in the carpal tunnel, so it doesn't cause this thing. But this is so superficial that it will bleach and kill your melanocytes there.
Wow. And then there is some systemic absorption of the steroids as well, and we talked about that as well with now in the big topic of COVID and vaccinations and immune suppression. So does that occur as well?
So for about 2 weeks, you do get a little bit of steroid in your system. It's not a lot, but right now we just don't have enough evidence to tell you yes or no. You should get the injection, around a COVID, to say, vaccination. And my suggestion right now in my office is, look, if you get the injection, like the COVID vaccine, wait 2 weeks to get your steroid injection, just because, it takes about 2 weeks to get your antibodies. So.
All right. And so we'll go back to the core veins. So you see the mom, you put a brace on her, you inject her, she doesn't get any blanching or bleaching of the skin. Do they need surgery?
So on a rare occasion, we do need to do surgery on someone. And the surgery is very simple. You just make a small incision over the end of the radius, usually about 1.5 centimeters. And then you just release the little cover over the tendons. Interestingly, a small percentage of patients, or not small, a significant portion of the population, like I would say 50% of the ones I take to the operating room, have a septum in there. And it's very interesting because normally it's just one compartment. And it's sort of like if you had a nostril, if you had a wall inside your nostril, and now it's smaller, so it's just harder to breathe through. The same thing happens here. They have this septum that forms, and it's an anatomic variation, but it's typically seen in people who fail the injections because they have an anatomic variation that makes them more susceptible to having a tighter space.
And so do you take out the septum, or you just unroof?
We unroof and then excise that septum. But it's really important to look for that septum, because probably the number one reason why a de Quervain's release would not work is that someone didn't recognize that there was a septum there.
Wow. Incredible. So we've learned from Dr. Miki 3 important health topics. We've learned about carpal tunnel syndrome. We've learned about the distal radius fracture, from the fall. And we've learned about the core veins as well, the new mommy syndrome, I guess it is.
Yeah.
Let me ask you, as we begin to close our program, any type of recommendations in regard to health for the hands and the arms? I heard you say, jackhammering, maybe you shouldn't be doing that. If you are, we're compression. So are there any pieces of advice that you can give our viewers with regard to good health for your hands, for your arms, up to your shoulders?
I think that, in general, being active is good, but if you're going to go to the weight room, if you're going to go and do gardening, if you do construction, wear some protective glove, because the hands are very sensitive. They're not indestructible. We do have the technology to replant and put things back on after they've been sawed off or chopped off, but obviously you don't want to do that to begin with. And I think that we didn't talk about trigger finger. We didn't talk about some of the other things that can happen in your hand. But if you keep repetitively hitting it, with gardening tools and stuff like that, those tendons and those structures do take damage, and they will swell up on you. And if you're 20, you can pretty much do anything you want. But after that, you sort of got to take care of it, and you got to manage it and use. I mean, this is why we have gloves out there to protect these weightlifting gloves, gardening gloves to protect the hand. I mean, I can't name the number of people I've seen from these thorns that people get from, these date palms, because they're ornamental date palms are, they're super popular here in Miami, and people get stuck with these all the time in Miami, and they cause terrible infections and terrible, abscesses.
Wow.
So people really need to protect their hands.
Wow. Okay. And so let me ask you, the people that you see with like these heavy callous hands, let's say those people that are doing a lot of physical work and not using, does those callous hands protect your hands already? That thickness that you see of the palms and of the fingers?
To some degree, yeah, they do protect you. And so I'm not saying that, it's perfect, but it does protect you for sure. But there are areas where, like, for example, you don't form calluses here. And, when you grab a weight, you put it right there. And that's actually one of the reasons why I probably like, when you're weightlifting and stuff, like, you can't irritate these tendons, because there's nothing protecting here. From here, there's like a sheath over the tendons. But in this area, there isn't. So, that's why wearing a glove that, you can cut the fingers off the gloves and just protect the palm area. And it's good enough, because this is the area where the tendons are protected.
Wow. Great information. So I told you guys, I'll always bring you somebody who knows what they're talking about. He even brought us some toys for us to play with. So I want to thank Dr. Miki to come and talk to us about all these hand conditions. Remember, if you can't sleep at night because your hands are hurting, if you can't lift up your baby, God forbid you fell and broke your arm, see your hand surgeon. Of course, Dr. Miki, who takes care of my family, would be one great option. So once again, I want to thank you for coming and joining us today.
Thanks, Tony.
All right.
It was really fun.
And from Miami Community Health, Dr. Anthony Gonzalez signing off.